and others for this privilege. So I will actually take you through one of the surface trials, which is mainly focusing on the comparison of the two molecules. A very good molecule, you all know semaglutide. We have used the oral form, and very soon we will be using the injectable form. And we have already discussed about some of the cardiovascular benefit aspect. This is the disclaimer. And so we talk about the incretin effect first. Actually, Michael Nock, which is a father figure in this science, way back in 1985 published this very physiological cartoon. Actually, it tells a lot about things about how our glucose is metabolized and how insulin acts. Actually, contrary to what we used to believe, that IV glucose will stimulate more insulin, not oral glucose. This incretin effect actually nullified that. Actually, it has been found that oral glucose is a better stimulant. It's not because the oral glucose is absorbed when it goes to pancreas and secretes insulin. That's mainly because of two hormones, GIP and GLP. And that's why once the glucose is in the stomach, there will be more secretion of insulin from the beta cell. Not simply because the glucose goes to beta cells and secretes. And that's the incretin effect, mediated by these two incretin hormones. I will talk about that shortly. So GIP was the first hormone actually discovered in 1970s, and it is secreted by the duodenal K cells. On the contrary, GLP, which we all know now, almost 10 years we have been talking about it. Discovery came in 1980s only, but the drugs were developed. GLP-1 receptor analogs were developed earlier than that. Extended base or liraglutide and now semaglutide. And GLP is secreted physiologically from the distal ileal L cells. So that's why once glucose is in the stomach, the duodenal K cells will signals the secretion of GIP, and that becomes a more potent incretin hormone. And if we look at GLP activity, there are very interesting facets to it. In the central nervous system, it reduces food intake, again that is mainly mediated by GLP. So GIP potentiates the action of GLP at the brain level, hypothalamic level, and increases satiety and decreases hunger, but it also causes nausea. It's a important parcel of GLP-1 receptor activity. So this is a little bit of price we have to pay to reduce obesity and hunger. In the pancreas, it increases insulin secretion and reduces glucagon, and stomach, it delayed gastric emptying. That's the GLP activity we all know. And how does GIP activity happens? It reduces food intake. Again, it is potential GLP-1, and it decreases nausea. This is something different from GLP-1. In the pancreas, it increases insulin secretion directly and increase glucagon in a glucose-dependent manner. That means at a hypoglycemic level, glucagon is secreted more. At a hyperglycemic level, it secretes insulin more than glucagon. Rather, it counterbalances the glucagon by secreting more insulin and causing normal glycemia. There is another important aspect to GIP activity, which is the adipose tissue, which GLP doesn't have. In the adipose tissue, there are receptors, GIP receptors. When stimulated, they increase the insulin sensitivity, which allows the adipose tissue to take the NEFA, non-essential fatty acids, into the fat cells, and the NEFA is stored in the fat cells, so it is good for the lipid metabolism. And there is lipogenesis from glucose also. Glucose is converted to lipids, so the glucose is lowered in the circulation. And it also reduces certain pro-inflammatory immune cell infiltration, which is also very essential for physiological lipid metabolism, which is friendlier for a patient. So in the pancreas, as I have said, GLP both act, but the most of the incretin effect comes from the GIP, which is more potent, secreted from the duodenum. 44% of the entire insulin secretion happens because of GIP. 33% directly from the glucose stimulation at the beta cell level. We all know about it. Glucose is metabolized inside the cell, and it stimulates the beta cells to secrete the stored insulin. And finally, GLP, which we all know about, we have used also, it contributes increased to 22%. So endogenous GIP generates a more significant effect on the insulin-mediated glucose clearance compared to GLP. So in nutshell, GLP is a better insulin secretagogue, GIP is a better insulin secretagogue, and GLP is a better hypothalamic hormone, so reducing appetite and reducing obesity finally. So I have already talked about the unique action of GIP in the adipocyte, so I quickly pass this try to talk about the tirzepatide in the remaining minutes. So tirzepatide is a molecule we are talking about. So tirzepatide is basically derived from the native GIP sequence. I mean, it looks like GIP, not GLP, but it could be a serendipity or it could be just a focused scientific mindset which brought in the GLP activity also by way of addition of certain amino acid into the whole chain. So then it became a dual agonist acting on both GIP receptor as well as GLP receptor. One important point is that its half-life is 5 days. That makes it a very good molecule for once a week dosing, and there is no requirement of dose adjustment in patients with renal or hepatic impairment because it's a simple peptide. So peptides are digested everywhere in the body by, there are certain proteases which can digest the peptides, and you don't need the kidneys to actually filter it, and it is not toxic to the kidneys. The mechanism of action of tirzepatide in nutshell in the central nervous system decreases appetite. Again, it is mainly because of the GLP activity, decreased food intake. In the liver, decreased liver fat content. In the pancreas, it increases insulin secretion and decreases glucagon secretion if there is hyperglycemia. If there is hypoglycemia, the glucagon secretion increases compared to insulin, so it counterbalances that and make the patient glycemic. In the stomach, it reduces gastric emptying, again mostly because of the GLP-1 activity, and there is systemic action which is increasing insulin sensitivity, which is again more because of the GIP than the GLP.